Hello, everybody. It's a pleasure to talk to you about this most important topic today. There is a handout that's attached to the Hellbender website, which I have on my last slide. There'll be a time for questions at the end. Please type them into the Q&A section on your screen. Dr. Michael Osterholm, an epidemiologist at the University of Minnesota, said, "We might be done with the pandemic, but the virus is not done with us." He also said, "There's a lot more we don't know about how SARS-CoV-2 spreads than we do know." And I suspect the same is true about the entire topic of COVID-19. With that in mind, before we can talk about Omicron and long COVID, et cetera, we need to get some terminology down. Anyone remember the SARS epidemic of 2002? Well, because the current pandemic's virus so closely resembles that epidemic's virus, experts named this virus the Severe Acute Respiratory Syndrome Coronavirus 2. A lot of words, abbreviated SARS-CoV-2. The illness it causes is called COVID-19. For coronavirus disease 2019, the year in which this pandemic started. For perspective, let's look at some other coronaviruses. There are 4 types that make up about 1/5 of the common cold. And in addition to the SARS virus of 2002, the Middle Eastern Respiratory Syndrome virus of 2012 was also a coronavirus. So what is a coronavirus? It's an RNA virus, that is to say, it has RNA as its genetic material. It's enveloped, which means it has a capsule, and it has a corona-like rim around the margins that's visible under electron microscopy. That looks a lot like the corona around our sun. This is our sun doing a solar eclipse. You can see the corona kind of in white here, and that is the resemblance to the coronavirus SARS-CoV-2 shown here in a schematic. You can see the red spike proteins that make up that corona, and they're attached to the olive viral envelope there that circles the inner purplish genetic material that is RNA. So what does the culprit that's been causing all this carnage actually look like under an electron microscope? The reddish orange spheres you see, there are 4 of them here, are the virus that causes COVID-19. The turquoise corona-like rim is made up of spike proteins. The size of these viruses is about 0.125 microns in diameter, which is the same as saying 125 nanometers. If you laid them side by side, it would take 7 million of these viruses to make a yard. Give you some idea of how small they are. Here's a close-up view. You can see the spike proteins pretty well here. Let's say you might be on a crowded bus or airplane. We forgot our mask. No one else was wearing a mask. We breathe in this virus. It lands in our throat or our windpipe and comes up against one of the cells that lines our windpipe or throat. That's called an epithelial cell. In this schematic, which is roughly 1,000,000 times under magnification, magnified 1,000,000 times, excuse me, this is that epithelial cell lining our throat or windpipe. And this is the coronavirus capsule here, or envelope. These are spike proteins in purple and gray. And this particular spike protein has bound to a receptor on our epithelial cell in our throat. It's called an ACE2 receptor. And this starts the attack on the human cell. This is also magnified a millionfold, this schematic, and you can see this is the human cell wall. This is the virus capsule. These are spike proteins in green. And here's a spike protein that has attached already to our human cell. And then this happens. The viral capsule fuses with the cell membrane of the human cell. And that's when all the trouble starts. In this schematic, also magnified a millionfold, here is our human cell in blue and purple with a green nucleus. Here is the coronavirus. Spike protein has already attached to the cell wall and is extruded. It has fused with this cell and extruded this purple genetic material, RNA, released into our cell and has taken over our human cell's internal machinery. It replicates both the RNA and the rest of the proteins to make another complete coronavirus. Matter of fact, it makes hundreds of them, maybe even thousands. And what this really looks like in the human body is shown here. Here is that human cell equivalent. You could call it an epithelial cell in our throat. And all of these round blue-green objects are SARS-CoV-2 viral particles emerging from this cell. What happened, this cell was taken over by one single virus to start with and turned into a factory, making thousands of these coronaviruses, which then go on to affect other human cells. So when someone gets coronavirus, COVID-19, this is how the inside of their body actually looks at the microscopic level. Variants have been in the news a lot lately. I guess the first question is how we pronounce this number 4 here. There are 4 different possible pronunciations. Merriam-Webster says Omicron. Omicron is the most common American, so I guess anything goes. But like other viruses, SARS-CoV-2 evolves over time. You have random genetic mutations that creates thousands of variants. A very few, actually become variants of concern that have special characteristics that make them much more dangerous to humans. You see some listed here, the alpha, the beta, and then the delta, which came out of India in December of last year and actually became more aggressive and contagious than anything else, started that worldwide surge, which we experienced from June until the end of last month. And then Omicron came on the scene from South Africa and Botswana last month, reaching here about the 1st of December. And this schematic shows on time on the horizontal axis and percent of the total variant US composite marketplace, if you will. And you can see that early on, Alpha was an important player, but then Delta just completely took over the US coronavirus picture until the 1st of December, when the Omicron came on the scene. Mr. Osterholm, the epidemiologist at University of Minnesota, thinks we're going to have a viral blizzard of Omicron. Those are his words. Now, Omicron is unusual in that it has up to 50 new mutations. It spreads twice as fast as Delta, and it partly dodges our immunity from prior infections. We don't yet know its severity. Here's a schematic of Omicron. you can see that it has 32 new mutations just at the spike protein, and another 10 here at something called the receptor binding domain, which is a part of the spike protein. It is the predominant variant in the United States now. Of these variants, when we talk about variants, there's three main issues that we look at: the transmissibility, the severity, and immune evasion. Omicron, it turns out, spreads, as I mentioned, spreads quite rapidly. Its severity, and this is South African data we have here. We don't have much from the United States yet. In adults, they had a lower hospitalization and ICU rates than earlier variants did. They had fewer deaths than expected. All good news, these. But for kids under 18, they had higher hospitalization rates. Now, as to immune evasion, an important thing to keep in mind is that the immunity of previous infections or vaccination gives you less protection against Omicron. As far as reinfection, in South Africa, they found a 3 to 8 times increased risk of people getting COVID twice. In the United Kingdom, which got Omicron before we did, there was a 5-fold increase risk of reinfection, people getting COVID twice, the second time with Omicron. So prior infection is not protective against Omicron. As we'll see later, 3 shots of Pfizer do protect us against Omicron. However, our data is incomplete in all of this about Omicron. We're just now beginning to understand parts of it. I want to take you to Scandinavia briefly. This is Oslo, Norway. On November the 26th, in Oslo, 120 people attended a holiday party at a restaurant. All were vaccinated. All were supposed to be antigen test negative within a day or so or two of that party. 10 days later, over 70 people returned positive for Omicron. Another 45 people at the same restaurant were also positive for Omicron. None have been hospitalized that we know of at this time. So the idea of transmissibility, you can get an idea of that from how many people at that party who were vaccinated but not boosted, as best we can tell. Norway didn't start giving boosters until the middle of November. And even then, they only gave boosters to people over 65. It also gives you a hint of its severity in that nobody has been hospitalized at this point. So kind of a mixed picture here. What exactly is an incubation period? It's the number of days from when the virus first enters your body to when you first have a symptom. For Delta, that was 4 days. For earlier variants, it was about 5.5 days. And for Omicron, it's looking like it might be about 3 days. In some cases, for earlier variants, it's as long as 14 days. Now we know that, and this is data about the situation from including Delta, but not including Omicron, up to 40% of infections are actually asymptomatic. You have no symptoms throughout the course of the illness. Most symptomatic infections are mild, and there's that 15 to 20% of symptomatic infections that are severe with hypoxia, that is low blood oxygen, and pneumonia. Conditions that make one more likely to have severe disease, this is from a CDC website, are cancer, heart disease, COPD, other chronic lung diseases, chronic kidney or liver disease, diabetes, stroke, being overweight or obese, being a former or current smoker, pregnancy, or age over 65. So if you find yourself in one of these groups like I am, be extra careful, wear a mask, get your shots, and get a booster. So let's say you're tired of this pandemic like I am, and you decide you want to go eat at an indoor restaurant, or maybe you're on the board of a small organization with 10 members. There's a board meeting scheduled. How would you assess the degree of risk for COVID in such a group? Well, fortunately, Georgia Tech has put out a risk assessment tool. And for event sizes of 10 to 5,000, it'll calculate the chance of at least one person having COVID in a group for any county in the United States. It factors in both the current level of COVID-19 in the county and the population vaccination rate of that county. Website looks like this. And so let's say again, you had a board meeting and there were 10 people coming, you'd move your little icon here over to the far left to the number 10, and you'd go over and find your county on the US map, and it would show you that there's an 8% chance that someone in that group of 10 would have COVID that week in that county. Now, on the other hand, the Lady Vols has been having a good year. So suppose you decided you wanted to attend a game in Knoxville at Thompson Bowling. Well, same thing, you'd move this bar over to the far right to 5,000, hover over Knox County, and you see there's a 99% chance of someone in the group, probably more than one, having COVID. You might want to catch that game on TV. I think this website is particularly helpful for intermediate sized groups when you can move your cursor to the middle. Say you had an event of 50, like what we expected for our meeting a week ago. I gave this talk previously with modifications. And you'd find out for a group of 50 a week ago, there was a 34% chance of someone having COVID in the group. So we decided to move it to a Zoom format. The website, a link to it is in your handout. Transmission. Now, one thing that affects transmission is how contagious a particular disease is. The basic reproductive number, also called R0 or R0, is a measure of the contagiousness of a disease. It is the number of people one person will infect with a particular contagious disease in an unimmunized, non-immune population. Measles is about the most contagious disease we know, with an R0 of 15. Chickenpox not far behind with an 8. Polio, you see 3.5. The original COVID is 3, about that. You can see Delta was much worse at 6.5. And we think Omicron might be as high as 10. Jury's still out on that one. Now, this basic reproductive number helps us because it gives us a way to determine a population's immunity threshold and the immunization coverage needed to stop a disease. You can take this formula, 1 minus 1 over their basic reproductive number, and it'll give you the percent of the population with immunity required to stop the spread. If you plug 15 in here, you come out with measles needing 93% of the population immune to stop it. The Delta coronavirus, 85%. And Omicron, we're thinking is around 90. That's guesswork, but it'll probably turn out to be over 90%. Currently, we have 62% of the total US population fully vaccinated against SARS-CoV-2. That's a long way from 85 or 90%. It is unlikely the United States can reach that percentage without a vaccine mandate. So transmission, it's almost entirely respiratory. A virus can linger in indoor air for hours, and that's where almost all of it is caught. It's person-to-person transmission by cough, sneeze, singing, speaking within 6 feet of another person. Much less commonly if your hands are contaminated and touch your eyes, nose, and mouth. We at one time thought this was a big part of transmission, but in more recent months, it's been found to be almost rare. The CDC defines close contact of a person with COVID-19 as 15 minutes within 6 feet within 24 hours. risk increases with the closeness and the duration of contact, and if you're indoors, especially if you're poorly ventilated indoor space. High risk exposures are things like cruise ships, homeless shelters, prisons, nursing homes, college dorms, food processing facilities. The CDC did a modeling study. This was with Delta, and they showed that 59% of COVID-19 transmission came from people with no symptoms. Think about that for a minute. That's part of what makes this pandemic so hard to control. Super spreader events, they are major drivers of this pandemic. In March of 2020 in Washington State, a church choir practice had one symptomatic case. Turns out that of the 61 members of that choir, 53 got COVID, 2 died. Who knows how many people were secondarily infected after that? There was the notorious Massachusetts Biogen Conference, in which 100 executives came from around the world the month before, February 2020. They went home after this weekend, and we think they infected 300,000 people around the world. More recently, there was the Anime Conference in New York City, 4-day conference. Looks like it might turn out to be an Omicron super spreader event. 53,000 people attended it. I haven't seen anything but very early numbers. 15 people came down with Omicron. All were vaccinated. All had extremely mild disease. One was a little sicker, but not hospitalized. So other high-risk exposures, travel. One study of one flight flying from London to the Far East, 62% of airline passengers traveling in the same business class cabin with a COVID case. It was a 10-hour flight. 62% of these people got COVID-19. And if you were within 6 feet, it was even worse. 11 out of 12 people got COVID. I think a bus or a train would put you at similar risk, depending on the length of the trip. Air travel, domestic air travel within the United States, CDC talks about delaying your flight until you're fully vaccinated. They say if you must travel, get tested before and after your trip. For international air travel, CDC says do not fly if you're not fully vaccinated. Now, safety is improved on airlines by their very good ventilation and filtration systems, and the fact they're pretty strict with masks. Safety is decreased by the fact that you've got prolonged close proximity to others. You've often got food served on flights, so people take their masks off. You're going to have more unvaccinated domestic travelers, and airport ventilation and filtration systems are not that good. I've seen 5 different studies that show transmission can occur on airplanes. I'm personally not comfortable with air travel, but if I were to fly, I would wear an N95 mask the entire flight and not eat. Now, CDC advises against all cruise ship travel if you're at increased risk of serious COVID, like we showed you on a previous slide. I noticed yesterday there were 48 cases on a Royal Caribbean ship called Symphony of the Seas. There were 6,000 people on that ship, so I shudder to think how many cases will eventually occur. Spain, France, and Canada now refuse entry to anybody that's unvaccinated. The CDC has moved many European countries to do not travel status, as you can see, including France, Germany, England, and Italy, etc. There's an excellent AARP article entitled Coronavirus and Travel, What You Should Know. There's an article link in your handout. The CDC COVID-19 webpage is also quite good. You can find that with Google. So symptoms of COVID. Interestingly enough, only half the people with COVID have a cough. About that many have a fever as well. Myalgias, which are muscle aches, in about a third, as is headache and shortness of breath, which is dyspnea. You see sore throat and diarrhea in about 1 in 5. You see nausea and vomiting in 12%, loss of smell or taste, belly pain, and a runny nose in about 10%. No specific clinical features reliably distinguish COVID-19 from flu or other viral respiratory infections. So you've got to be tested. It looks just like flu initially, as well as other viral respiratory infections. This is one thing that makes COVID quite different than flu, one among many things. 1 out of 80 people who have acute COVID will have a stroke at the same time. This is 6 times the rate of stroke that you have with flu. COVID is a bad disease. And if you make it through the length of regular COVID, you've got to worry about long COVID. It's also known as long haul COVID. What exactly is long COVID? It is symptoms that occur or continue 30 days after the initial diagnosis of COVID-19. You can get long COVID even after asymptomatic cases of regular COVID. It's about 1 in 4 COVID cases that will lead to long COVID. And it includes things like brain fog, which is memory loss plus an inability to think clearly. It also includes fatigue, muscle aches, persistent shortness of breath. You can have altered smell and taste that's almost permanent. It may be permanent. It can affect your ability to walk, give you diarrhea, abdominal pain, a cough, and a racing heart, and other symptoms. CDC's got a good website on that. Our scientific knowledge is still limited about this area. And as you see, the NIH is putting $1 billion into studying it now. The US government calls it post-acute sequelae of SARS-CoV-2, or PASC. And we badly need more research on this. Some of the symptoms you see with the frequency that they're seen with long COVID: shortness of breath, fatigue, chest pain, cough. It lasts at least a year in many cases, and many people have more than one symptom. We think that there are autoantibodies, that is, antibodies generated in the acute COVID illness that are directed against our own bodies, such as directed against the inside of our arteries and veins, in which case they might cause a blood clot or the stroke we mentioned earlier. Almost half of COVID-19 survivors report decreased long-term quality of life. Right now, 1 million US patients are already disabled by long COVID. Another study this year found that cognitive decline was 18 times more likely 6 months after mild symptomatic COVID than in people who had not had COVID. It's unclear if this brain fog is permanent, but it's a really good reason to wear your mask and get boosted. So testing, there are 2 main categories of COVID-19 tests: the antibody tests, which are serology or blood tests, and the viral tests. The antibody tests find past infections. They tell you if you've ever had COVID-19. 2 weeks after you get COVID-19, they turn positive. So they're not helpful in the acute illness. If you have long COVID symptoms, you might get an antibody test to see if you had a past infection if you did not have the vaccine. The viral tests find current infections. There are also 2 main types of viral tests: the PCR or molecular tests and the antigen tests. Now, the PCR tests are the gold standard for COVID tests. They're almost 100% accurate. They read the coronavirus RNA indirectly by amplifying it. You find them in hospital labs, doctors' offices. They take a while to get results back, 12 hours to 5 days. They're expensive, around $100, and they may be positive for weeks after the infection is over. Antigen tests you can do at home. You get results in about 15 minutes. They cost about $25 for a pack of 2 tests, and they're about 80% accurate. They may miss some early infections. I got these 2 boxes from Amazon. They were about $25 per box, and each box has 2 test kits in it. I called today, and Amazon still has 8 different types of antigen tests available. I did also check, my wife helped me check CVS, Walgreens, and Walmart today, and the stores nearest us in Knoxville were out in all 3 places. That's just one store of each type, though. I don't know about the rest of Knoxville. I would suggest you consider buying a few of these from Amazon and keep some at home. There's some recommended brands of the antigen tests that are best to get in your handout. So antigen tests tell you if you're contagious. So when would you test yourself? Well, if you got a call from the health department saying you were a contact of somebody who was positive for COVID, if you were vaccinated, you'd wait 5 to 7 days after you were around that person to test yourself that one time. If you were unvaccinated, you test yourself immediately and a second time 5 to 7 days after exposure. You might also test yourself before you go visit your grandmother over Christmas. In that case, I would test myself the morning you went to her house, and perhaps the morning before, but definitely the morning you were at her house. You might also test yourself if you had symptoms of COVID. Remember, these tests are just a snapshot in time. You can be negative today and positive tomorrow. They're good for one day only. If you travel through an airport or on a train or actually attended a UT football game, you might consider doing these tests serially afterwards, testing about every other day for 5 to 7 days. That improves accuracy. I saw in an article that a Dr. Doran of Tufts University Medical Center recommended this brand highly. It is emergency use authorized by the FDA for serial testing, and it's pretty good at picking up Omicron. Walgreens had it at one store, had a couple tests last week. I don't know what's available now. I'd mention also that you may have heard President Biden's going to offer free mail-out rapid COVID tests in January, which you'll order off a website. Look for details in the next few days. So what if you had a positive home COVID test? What would you do? You'd put on a mask. You'd isolate at home for 10 days until you knew more. You'd call your doc and watch for symptoms. You'd want to confirm this test at your doctor's office or perhaps the health department. And when you're isolating at home, you want to try to use separate bathrooms if that's possible in your house. And you want to avoid pets. So if you had that positive home COVID test, when would you seek emergency care? If you had trouble breathing, you had chest pain or pressure, you got new confusion or the inability to stay awake, your skin turned blue, your lips, nail beds, pale gray or blue, those would be good signs to head to the ER. Now, I wanted to give you a sense of how COVID is handled in other countries, some of whom have done a much better job than we have. Now, about the middle of last month, in China, there's a Disneyland in Shanghai that was locked down. All 30,000 park visitors were tested. All were negative. About 70,000 other people who had been in the park the previous day were also tested. They were all negative. All this testing was done because a previous day, a single visitor at the park had tested positive. Now, China's total cases countrywide for that day were 54. They were aiming for 0. That same week, the US averaged 75,000 new cases a day. You can see the population of China is about 1.5 billion. The United States, about 334 million. China's their records show 130,000 total cases from the start of the pandemic. We've had 51 million. Their total deaths, 6,000. We've had over 800,000. And you can see the percentage of the population fully immunized. I think yesterday, China immunized 8 million people. Now, I'd be the first to admit that China is not known for transparency or honesty in the information they release. But if you take their total deaths and multiply it by a factor of 10, you still get 60,000 deaths, which is a phenomenal achievement under these circumstances. I believe that if things had gone better, been managed better the first year of our pandemic, we could be near that 50,000 death mark. To give you a better perspective on other countries that have managed this pandemic well, take a look at these three below our numbers here. You can see the percentage of people vaccinated in Japan, South Korea, and Australia. And you can see the case numbers, and particularly notice the death numbers here. South Korea, a country of 52 million people, they've got about 1/7 the population that we have. You multiply this number by 7, you get about 30,000. The same with Australia, half the population of South Korea, they got about half the deaths. Even Japan, who's got over 1/3 as many people as we have, you multiply this by 3, you get about 60,000, a little less. Now, how did these countries do this? Well, if you look at Japan, they have extremely high mask wearing in that country. You can see their vaccination rates. South Korea tested very early and very frequently. They invented a test before we had one, and they test, trace, and isolate it religiously. And when they put somebody in quarantine, isolation, they sent a nurse to their home to support them. They never had any shutdowns. They also have high mask wearing. They use GPS to track contacts of COVID cases. And interestingly enough, in December of 2019, their 24 top health officials went through pandemic training games to prepare them. Australia took a different path. They went through lockdowns, and they have about 7 states, give or take, in Australia, and they closed the state borders. And if you try to cross between states, you had to go through a 2-week quarantine period. They put in a curfew at 9 o'clock, and they look at freedom differently in Australia. They look at it more like a collective right with responsibilities. I like that, a collective right with responsibilities. You can see their vaccination rate as well. Here are yesterday's new cases worldwide. That's 1 day total. The US case numbers, 139,000. We lead the world again. You can see Great Britain is second and so forth. Let's talk about masks. First thing I'd say is that masks work. There's a Vanderbilt study in Tennessee that examined Tennessee counties with mask mandates and those without, and found that those with mask mandates had half the COVID death rate as those without. Let me show you the numbers. The vertical axis is the COVID death rate. The horizontal is the year 2020. It is the week of that year. And you'll see this tan area is actually the time when mask mandates began in some Tennessee counties. For instance, the gray line is those counties that started a mask mandate early. You can see how the death rate plummeted after that. The black line is those counties in Tennessee that put in a mask mandate late, and their rates also went down. On the other hand, the red line shows counties that never had a mask mandate. Double the death rate as those counties that had none. Masks do work. Now, the New York Times recommends this article, which is an excellent online summary article from Wirecutter. It tells you all you need to know about masks and with links to purchase the best ones of each type at good prices. The web address is in your handout. These are the filtration standards of different types of masks. The N95 is the best mask. It takes out 95% of 0.1 micron particles. The KN95 is the one that must meet Chinese standards, 95% of 0.3 micron particles. That's a big difference. The KF94 is a Korean mask, same standard. The FFP2 is a European mask, same standard. Notice how much better the N95 is. All these filtration levels of these masks depend on getting a good fit. Key part of a mask is how well it fits. The N95 NIOSH certified mask or respirator, same thing. A mask is the same as a respirator in this case. They have head straps, not ear straps, moldable nose bridge. These are the best of the masks. Here's a picture of one from that article from Kimberly Clark. These are 84 cents a piece on Amazon. National Institute of Occupational Safety and Health approved. It is the best mask. The KN95 masks are ubiquitous. They're designed to meet Chinese standards. The CDC has put out a notice, though, that 60% of the KN95 masks that are sold in this country are counterfeits. That is, they do not meet the standards, don't come close to the filtration standards that they're supposed to. So how do you sort through this maze of KN95 masks to find a good one? I would recommend, again, this Wirecutter online summary article. It's a great guide to finding good KN95 masks at reasonable prices and with links to purchase. Here's one from that article. These are 90 cents a piece. Here's a surgical mask from that article. These surgical masks can be made much more effective with what's called a knot and tuck technique. If you use that knot and tuck technique, which I will show you on the next slide, with a surgical mask, it can reduce your COVID-19 exposure by 77% per a CDC study. Here is that video that'll show you what this technique is.
There's a simple way to make your disposable mask fit better, which can make it more effective in protecting you against COVID-19. First, fold the mask from edge to edge. Then, make a knot in each ear loop. Push the knot as close to the edge of the mask as possible. Next, fold and tuck the extra material under the edges of the mask. Hold the mask up to your face and gently push the nose wire against your nose so it fits snugly. Place the ear loops around your ears as you normally would to secure the mask. Be sure to remove any gaps in the mask around your nose and cheeks for the best protection. And this is what we call knot and tuck.
So this is what knot and tuck looks like on a surgical mask. You can see the knot here. It's been tucked in here. Great way to improve filtration. Another way to get excellent filtration is to add a cloth mask over a surgical mask. That improves the seal and can get filtration up to around 83%. with surgical masks. Also a very good technique. Here's an unusually good surgical mask, again, from that same article. These are 20 cents a piece, and with good filter, with a good seal, can get you up to 95% blocking of 0.1 micron particles. Combined with that knot and tuck technique, that would be a great mask to use. Are masks reusable? That's uncertain. You can leave one on the dash of a car and turn it over after 20 minutes. This is unproven, but sunlight does kill COVID on surfaces in 20 minutes. Good chance this would work. I use this technique. The CDC says you can also, at the end of the day, take your mask off, put it in a breathable paper bag, and save it for the following week. We think that if you take 7 paper bags and put 1 mask a day in each bag at the end of the day, and then the following week you could start on bag 1, and we think that would work, reusing masks. Now, there's such a thing as a Hepa Air Purifier. This is a high efficiency particulate air purifier. It's around $200 from Amazon. It does filter the appropriate size particles from the air, 0.01 to 0.3 microns. You remember the SARS-CoV-2 virus is 0.125 microns, well within this range. This was the best one that was on another Wirecutter article. So if this might be helpful if, for instance, you had someone in your home who had a positive COVID test who was quarantined, you would close the door to their room and put this Hepa air purifier in their room, and it would remove the virus from the air. You can find this particular air purifier article. You can find the article that recommends this air purifier by Googling the best air purifier and then Wirecutter. Let's talk about treatment for a minute. Monoclonal antibody, there are 3 types that all worked well versus Delta and previous versions of coronavirus. They're generally combinations. The first 2 are 2 different monoclonal antibodies are given. They're all given IV or intramuscular, so you're in a hospital or in a clinic to use them. And all 3 had good results against Delta and prior versions of COVID-19. There's also an antiviral medicine called remdesivir that has more recently found to be disappointing in studies. The World Health Organization recommends against using that medicine. As far as Omicron, these first 2 monoclonal antibodies do not work nearly as well as they did against previous variants. The sotrovimab does seem to work well against Omicron in early studies. There are 2 new oral medications coming out probably the 1st of January or thereabout that hold great promise. Molnupiravir reduces COVID hospitalizations 30% in unvaccinated patients. You must start it within 5 days after you get symptoms, though. So that's a good reason to have a test, a home test kit, antigen test kit at home. This one's already being used in Great Britain. It's expensive. It's about $700 for a 5-day course of pills. I'm hoping and thinking insurance will help us there. Paxlovid has even more impressive efficacy. It reduced hospitalizations and death by almost 90%, but you got to take it within 3 days of symptom onset. So our arsenal of drugs against COVID is expanding. And as I mentioned, the sotrovimab works well against Omicron by early reports. And both the oral pills we're thinking are going to work well against Omicron. It is still true, an ounce of prevention is worth a pound of cure. With that in mind, let's look at vaccines. And by the way, do vaccines really work? We'll cover this later, but it turns out smallpox was a part of the third worst pandemic in world history. Vaccination eliminated smallpox from the face of the earth in 1980. Measles has almost been eliminated from the United States by vaccination, only 13 cases last year. German measles came down from 12 million cases 50, 60 years ago to 10 cases last year. Vaccination works. You can see that chickenpox, mumps, diphtheria, whooping cough all dramatically lowered cases and deaths with vaccination. Diphtheria came down from 200,000 cases to 1 case. These really are remarkable interventions. Vaccinations are to drop numbers that much. Many of us sitting here today might be deceased had we not been vaccinated against these illnesses as children. I want to talk about polio for a minute. In the 1950s and before, this was a common sight in the United States. President Roosevelt's legs looked like this. There were repeated polio epidemics here. This was a newspaper from 1946. Polio was feared by all, and appropriately so. Thousands of children were paralyzed. Vaccine misinformation was as common then as today. But polio vaccine was not a fake. Polio vaccination began in about the mid-1950s, and you can see the case numbers here of deaths, paralytic cases and deaths here, time on the horizontal axis. This is when the polio vaccine came into being and was used throughout the United States. And you can see what it did to the numbers, made them just plummet. And by 1979, it had eliminated polio from the United States. This is what vaccination can do against a deadly and crippling disease. Let us not forget the power of vaccine mandates. 96% of federal workers got vaccinated for COVID after President Biden's vaccine mandate was issued. That's the kind of numbers we need to beat this pandemic. We definitely need to get over 90% of the population vaccinated. Now, this is really important, folks. These formulas are not precise, but they yield very helpful approximations to guide us. I'm speaking about this formula here, which tells us if you put polio's basic reproductive number here, you come out with 72%, which is that magic percentage, the percentage of the population needing to be immune to stop the spread of polio. Over 90% of the US population is now immune to polio due to that polio vaccine mandate that caused us all to get about 4 shots before they let us in school. That is what eliminated polio from this country. Now, if you think about Delta COVID, its R naught is about 6.5. You put the same number in that formula, you get 85%, giving us the magic percentage to stop the spread of Delta in this country. Omicron is going to be higher. You come out over 90%, might be even this high. We don't know yet. This will require a vaccine mandate. Now, this is a little bit of an oversimplification, but this is what we need to get to have a chance to beat this virus. It will require a vaccine mandate. So there was a CDC study back in August that showed unvaccinated people are 29 times more likely to have to go in the hospital with COVID than people who are vaccinated. This is another study from California, San Diego County, mostly with Delta. The white line here is folks who are fully vaccinated. This axis being cases per 100,000, this being time last summer. The red line is people who were not fully vaccinated. And you can see the unvaccinated had a 9-fold higher chance of getting COVID as fully vaccinated people. Being not fully vaccinated is a mistake. Let's look at these two vaccines, Pfizer and Moderna, that are messenger RNA vaccines. The Pfizer vaccine is 2 doses, 3 weeks apart. We now can give it to people 5 years and up. It's gotten full FDA approval. It's no longer on an emergency use basis, fully approved. Moderna is 2 doses, 4 weeks apart, ages 18 and up. They requested full FDA approval. Here's some graphs. This is effectiveness against symptomatic infection on this vertical axis and weeks since their second dose here, 10 weeks here, 20 weeks here. And you can see that at 5 months, Pfizer was about 70% effective against symptomatic infection. Moderna was even better at about 90% at 3 months. This was prior to Omicron. Same with these slides. Likewise, effectiveness against hospitalization. This is 10 weeks, 20 weeks on the horizontal axis here. Delta predominant during this study. You can see Moderna was about 85% effective at 4 months. Pfizer, 95% at 4 months, even higher in the Canadian study. And that protection extended out quite a ways. Both are great vaccines. Now, this was a study done much more recently against Omicron. This is with 2 doses of Pfizer vaccine, and then a booster was given out here. And you can see that people this is weeks here, at 25 weeks. This was an unusual design study, as it had to be, because not much time has elapsed since Omicron hit the scene. It's called a test negative case control design. But basically it showed with Delta, this is Delta here, the square boxes, you got great protection here. But with Omicron, it fell off dramatically so that you were down below 40% for about 3.5 months and following with 2 shots. But when you got boosted, it jumped up to 75%. So the take home here is Pfizer works well, but you need 3 shots. Information about Moderna's booster is that it yields a 37-fold higher antibody titer against Omicron than 2 shots. They're coming out with a multivalent Moderna booster that yields similarly high antibody levels to Omicron. At least that's being studied, I should say. And they're also looking at a Moderna specific booster. Sometime they'll be testing that early next year. It's, an Omicron specific Moderna booster. Side effects. Pfizer and Moderna's vaccine, the main side effect that is extremely rare is myocarditis. That is inflammation of the heart muscle. There was an Israeli study of 2.6 million vaccinated folks, and they had 54 cases in 2.6 million who had myocarditis. Of those 54 cases, 41 were very mild. That gives you an incidence of about 2 per 100,000. A separate study in California found 15 cases in 2 million, all recovered in that study. giving you an incidence, though, of less than 1 in 100,000, starting with 15. You are 16 times more likely to get myocarditis if you get COVID-19, the disease, than with vaccination. So if you get COVID-19, you're 16 times more likely to get myocarditis than you are with vaccination. Easy choice. Johnson & Johnson's vaccine, one-shot course, ages 18 and older. They've not yet requested full FDA approval as of the first of the month. Side effects are quite rare. They are thrombosis with thrombocytopenia. That is blood clots with low platelets. They're seeing about 7 cases per million, mostly in women under 50. You can further enhance the safety of this vaccine if women under 50 just got Moderna or Pfizer, and men and women over 50 could get Johnson & Johnson. However, CDC has come out slightly favoring Moderna and Pfizer over Johnson & Johnson now. Let's talk about boosters. You get those 6 months after your second vaccine of Pfizer and Moderna. For Moderna, that's ages 18 and up. For Pfizer, it's now 16 and up. You can get a booster. You can take any of the 3 vaccine boosters after either shot. So you could get, after a Pfizer series of 2 shots, you could get Moderna, or you could get Johnson & Johnson. Likewise with Moderna. Now, if you talk about a booster for Johnson & Johnson, you take that one 2 months after that single first shot, and that can be any of the 3 vaccines. You can also take the flu vaccine at the same time you take a booster, and I'd recommend that. You need to get vaccinated for flu as well right now. This slide should be posted in every OB/GYN's office. For any lady who might become pregnant, is pregnant, or is breastfeeding, because 125,000 pregnant ladies in our country got COVID. 22,000 were hospitalized. 97% of those hospitalized were unvaccinated. There were 161 deaths, and women who got COVID had much higher rates of stillbirths, preterm babies, and their newborns have to be hospitalized for long periods of time after birth. Far better off to get the vaccine. We must vaccinate the world. Right now, it's 46%. We've also got to create COVID vaccines that target different viral parts that don't mutate so readily. And I think parts that are essential to its survival, not the spike protein, or where the focus should be in the future with modifications to vaccines. In closing, what is the pandemic's place in history? Well, this COVID-19 pandemic is far from over, but it's already the worst pandemic ever in the United States. You can see the numbers before you. How does it stack up with the world's worst pandemics of all time? Well, the short answer is number 6. You can see it here at the bottom. The worst pandemic was actually the Black Death, 1346 to 1353, 75 to 200 million deaths. It was the bubonic plague. We think that population, that number of deaths, was 20 to 50% of the world population. Imagine that. The Spanish flu was the United States' second worst pandemic and the world's worst pandemic, with 50 million total deaths worldwide. Good time for me to again remind you to get your flu shot. We talked about smallpox, and that was also combined with measles. Starting in 1520, the European explorers brought over those diseases to the Native Americans in North America. There were 25 to 55 million deaths. We think that was about 80% of the population of North America that died in that pandemic. Number 4, the Plague of Justinian, also bubonic plague, 541 to 542, 30 to 50 million deaths. Some scholars think that had a hand in ending the Roman Empire. The fifth worst plague was the third plague, also bubonic plague, 1894, 12 million deaths, China. So last slide here. What works against Omicron? Masks for one, 2 doses plus the booster of Pfizer and Moderna vaccine, and the Paxlovid pills that are coming out shortly. Before I take questions, remember this handout is on the Hellbender website at this web address. It's also here before you. So I'm going to return control back to Wolf Najili.
Well, thank you. Thank you very much, Dr. Reynolds. That is the most comprehensive and thorough discussion of COVID-19 that I have found anywhere. I've read a lot of articles, I've looked at lots of videos, and nothing has been so thorough and so up to date too. I mean, even since 10 days ago when you were, 8 days ago when you gave the presentation to the Technical Society of Knoxville, you have added and changed a few things that just have changed over this short period. And that makes it so difficult to keep abreast of, you know, what you need to do if something happens to you or your family in terms of reacting quickly enough to minimize the damages. And of course, in the first line, to be careful and to know how to protect yourself sufficiently. So now I'd like to introduce Thomas Fraser. He is the editor of the Hellbender Press, and he will present the questions to Dr. Reynolds.
Yes, Dr. Reynolds, thank you again for a very, very detailed overview, yet not so detailed we didn't wander off into the weeds. It was good stuff. What makes this virus so especially pernicious?
Good question. For starters, the fact that 59% of case transmission happens when the person infected has no symptoms. That alone is a part of a deadly disease. And that question really could be answered slightly differently for previous versions and then Delta and then Omicron.
Mm-hmm.
As you probably remember, the spread is almost exponentially more rapid with Omicron than cases before Delta.
Mm-hmm.
I think also long COVID, that's what keeps me up at night, thinking about if you get the original infection or any COVID infection, you got about a 1 in 4 chance of getting that long COVID, which really could affect you for the rest of your life.
Right, and
Yeah,
that could
so
be any percentage of the 50-something million Americans who've been infected with COVID-19. You know, I mean, it's not
yes.
just going to be they're sick and hospitalized and then they get over it. They might never be hospitalized, but they might never get over it because it's going to affect their quality of life and their health for years, potentially. But
Yes, well said.
I mean, but what is it like, just physiologically speaking, that this disease does that makes it so alarming and deadly?
One thing that comes to mind is the way I saw one study where when you have COVID, the acute illness, thousands upon thousands of autoantibodies are generated. There are a number of diseases that people get, like rheumatoid arthritis and lupus, et cetera, that have antibodies as one of the main causes of the disease outcome. Here we have an infectious disease that has that kind of effect. And we don't even have the data yet, Thomas, to know the full extent of long COVID. But we do know that autoantibodies are a big part of both acute and long COVID. I think that's safe to say. And so I would say that and answer your question. I don't know. I have the knowledge base to answer beyond that.
Understood. No, very good. So you mentioned that, we all have to get a raft of vaccinations before entering, say, public schools. And that's still the case, correct? I
It
mean,
is.
I seem to
Yes.
recall getting my daughter a number of vaccinations, and then I myself got boosters before her birth. Um, so what do you think the rationale is behind these anti-vaccine flare-ups we've seen lately, when considering we all have to get vaccines anyway? I mean, are people going to end up saying we shouldn't vaccinate our children against polio or rubella or measles? I mean, what's the, just seems to be some cognitive dissonance there.
That's a good question. So much seems to arise from misinformation and disinformation. And it's hard to say where some of it begins, but people seem to be following not science, but more to be honest, the TV channels and some of the things posted on places like YouTube that are just not scientifically based. Websites like the cdc.gov are a good source of reliable information. Johns Hopkins University COVID webpage is excellent. Tennessee Department of Health has got good statistics and more at their website. So I would urge people to proceed in that direction for their information. Ask their local doctor, and so forth. Yes.
Yeah, Johns Hopkins is especially good, that database. So where do we go from here? I mean, now we're on Omicron, in terms of the Greek alphabets, I guess. What's next?
There are thousands of more variants created, and we likely will encounter ones that are after Omicron. We must follow the guidance of the CDC. And if we can get a vaccine mandate in place, I think that's the best weapon we have against both the development of future variants and the current one, Omicron. We've got to be smart about wearing masks whenever we're indoors with someone from outside our home. We've got to listen to the CDC and follow that pattern that they recommend. We've got to find a way to vaccinate children down to, like ages 2 months against this disease, so they don't get COVID and bring it home to the rest of the family.
Mm-hmm.
If we can get the numbers up on vaccination through that, and they are working them lower, you can now vaccinate down to age 5.
Mm-hmm.
I think we're going to need new vaccines that are more specific to Omicron and future variants, and those will be developed. And I think that we'll end up taking a vaccination every 6 months, probably, as this process goes along. But if we've learned one thing from this pandemic, it's that it's not predictable. So everything that I say about the future has to be taken with that grain of salt.
Very true. And one last question. Could you walk us through like how these variants emerge, like how the components of the virus change over time and produce these mutations or variants?
Sure. This is all about random genetic mutations. That RNA we showed, the purple inside the cell, it mutates frequently at different places and results in a slightly different virus. And amongst these thousands of mutations and different variants, many of which have no consequence, there'll be 1 or 2, I guess it's been every 6 to 12 months, that have an advantage.
Mm-hmm.
They might be more contagious. They evade our immune system's immunity from vaccination to a certain extent, more commonly from previous infections.
Mm-hmm.
They might be more contagious in the previous version. They have, slight advantages, and they take over kind of the COVID marketplace, if you will, throughout the world, as Omicron is doing. And that's kind of how it happens. It all stems from that genetic mutation in their RNA, and the chance that one of those thousands of changes will turn out to be very advantageous to the virus. Yes.
And that's what it's all about, right? I mean, it's evolution, right?
It is, in a rapid format. Yes.
These viruses need hosts.
They do,
survive.
and
Yeah.
they do, and that's us. Yes.
Well,
I
again,
see.
thank you very much.
One more question, and I think that is a important one. If somebody would sneeze or cough in that person's face who is not wearing a mask, or even if person is wearing a mask, what would be the best thing to do when you feel the drip in your face? How should one deal with that?
If you could see that coming, it would certainly be to wear a mask and wear glasses. But once that's happened, I don't know. I would certainly leave that area so you don't get further exposure after that. But if they sneeze in your face and you breathe that in, there's a chance you might get COVID from that. I would certainly leave that space, that area, so further sneezes and coughs and whatever don't infect you. But you would assume that there is coronavirus in the air if this is indoors. And if you knew the person had COVID, if you had a clear-cut exposure to COVID, you might pursue, in some cases, you can pursue treatment. That's a little dicey in this country right now, but if you were vaccinated, you could wait 5 to 7 days and then test yourself with an antigen test. If you had symptoms, you would test right then at that point. If you were unvaccinated, you'd test within a day or so of the exposure, maybe 2, and then again at 5 to 7 days.
Thank you very much. That was a very interesting presentation. The handout you mentioned, link is here on that end page, hellbenderpress.org/news/pandemic-webinar, the list of the links that you can directly click and get to. And we will add a PDF file that you can download that also includes all of that information. And probably over the coming weeks, we might even add additional sources, interesting ones and useful ones become available. Well, thank you very much and good night.